Hello, everyone, and welcome to Henry Schein's July 2021 update on COVID-19 on YouTube. Today, we join Dr. David Reznik for his regular update, where he will cover the latest information, including the Delta variant, the status of state vaccinations, and the most recent ADA and CDC guidance, along with much more. Welcome, Dr. Reznik.
Thank you for the introduction, Dr. Severance. It's always a pleasure to be back with this month's clinical update on where we are with COVID. I think that if you've turned on the news, you're seeing a little bit of mixed messaging, and it looks like we have a problem with our unvaccinated. But let's see what the CDC is telling us to do. Let's see what OSHA is telling us to do, what the ADA is helping us out with, and then discuss a little bit in more detail what the Delta variant is and how well the vaccines are holding up. So we're seeing a little bit of a change. We're seeing a little bit of an uptick. And having the uptick now during the summer months is a little bit concerning for me, because I would expect, with open air, with people being outside, that our numbers would stay low. And even at my own hospital, our numbers had been low, but they're beginning to tick back up. And when I go over some of the states and you see the incredible percentages of increases that we're seeing now, remember their baseline numbers were low. So if you see a state that has a 500% increase, well, there might have been 100 cases in the entire week before, and now you're seeing 5,000 cases. So we'll go over it and we'll discuss it. And as always, we'll look forward to questions that come in and see what we can do to help answer those burning questions. So the Delta variant, what do we need to know? Well, it's across the world. We know that it's made up of certain mutations that make it more infectious, but we don't know if it's actually more deadly than other strains at this point. There's sort of mixed data on that, but we do know that viruses sort of change to adopt and survive. And with so much COVID and so many people that are unvaccinated, mutations are going to occur. And that's just how things are. But right now, our vaccines are doing an excellent job of keeping us protected. So I think you've maybe heard on a news clip or something, we are having a pandemic amongst the unvaccinated. Are there people breaking through? Yes, there are some people who are breaking through, usually medically complex people, sometimes older people, but we will go over that. The CDC and WHO monitor all of these variants to find out if transmission could lead to a surge in cases and deaths, as well as whether or not the current vaccines and treatments are still working, and those are important areas. There are different kinds of variants, and I did cover this once several months ago. We have variants of interest. So they might be something that we're going to look at. They might turn into something of concern, but right now they're not more contagious. They are variants. We are identifying them, and there's 7 in the United States at the present time. I'm not going to read through the numbers or even try to do the Greek here, but as you can see, one of them is P2, and that was the second variant that we found in Brazil. The variants of concern are the ones that we're actually dealing with in the United States right now, and there are 4 that we have that are being closely monitored. There's the Alpha variant, that was the first one that showed up in the UK, the Beta variant, the Gamma variant, which was the first one that was in Brazil, and of course the Delta variant, which is the one that we're dealing with around the globe right now. I believe 83% of the cases that we're seeing or infections that we're seeing are coming from the Delta variant in the US. The World Health Organization may classify certain variants in different categories because of the impact they're having in other countries. That is the World Health Organization. But right now, I think the most important thing that I can say is that there are no current variants of high consequence. And if we have variants of high consequence, then there's our disease profession, or disease prevention efforts are going to be not as effective. If we have a variant of high consequence, then they'll be going back to before we had actually these wonderful vaccines. So the goal is to try to keep this controlled, try to get people identified and stop the transmission. So with variants of concern, which is what we are dealing, a variant of the virus is considered to be concerning when it increases the risk to human health. The risk to human health could be increased because the variant is able to spread more easily, it's more contagious, possibly cause more severe illness, escape immune protection provided by available COVID-19 vaccines or by natural infection if you've had the virus before, make our testing less accurate, and make some of our treatments, our monoclonal antibodies, less effective. So that's why we watch these variants of concern and keep our eye on them, and why we really are trying to avoid having any of high consequence. And at this point, we do not have any of those. But I would like to go over the different 4 variants of concern that we see in the United States and what do they actually mean. So I have this chart I've put up here. We can discuss the Alpha variant. Like I mentioned earlier, it was first described in the United Kingdom. Its estimated spread about 50% more easily than previous variants, so it was more contagious, likely associated with an increased risk of serious illness or death. A minimal impact on immune protection, so it does look like vaccination or natural immunity is holding. There's no real impact to the emergency use authorization of monoclonal antibodies. So again, very important, and it really doesn't have an impact on diagnostic testing. The Beta variant is the one that we first saw in South Africa. Again, it's estimated to spread about 50% more easily than previous variants. So again, it's more contagious. Currently, no evidence of an increased risk of serious illness or death, but we are still monitoring. The key is that we are monitoring several things in the United States, but what we're looking at when it comes to COVID breakthroughs or people who are in the hospital, what variant is causing it? Was the patient vaccinated? And right now we're seeing a minimal number of people who are vaccinated breaking through, but a larger number of people who have not been vaccinated. So when they're not vaccinated, you know this is more contagious. The chances of getting sick and ending up in hospitals increase. We have the Gamma variant, or P1, that was initially found in Brazil. It's also believed to spread more easily, but we really need more studies to be done to see how much more easily it is spread. There's no evidence of increased risk of serious illness or death, and that's what we're really monitoring now in the United States for vaccine breakthrough. Is there a more serious illness or death? So we're only really looking at hospitalized cases, not cases where you test positive and you're at home. There's a moderate reduction to immune protection offered by vaccination or natural infection. And it does have some impact on some of our monoclonal antibody treatments. So I think that's one we're keeping an eye on. And then the one that we hear about constantly, which is the Delta variant, first discovered in India. It's spread more easily than other variants. It's thought to be 40 to 60% more transmissible than Alpha. And if you remember the slide I just talked about, the Alpha variant is already 50% more likely. So this is a highly contagious strain, which is why that's the #1 strain we're seeing in the United States. Early evidence suggests there may be an association with a more severe illness, but to be frankly honest, more research needs to be done that. We do understand there could be a reduction of immune protection offered by vaccination or natural infection, but again, that is being monitored. We're looking at boosters, or we're having the conversation about boosters. The people who are actually looking for boosters are immunocompromised patients. There's some information about possibly needing them in the HIV community. We know the underlying #1 condition that leads to bad outcomes is diabetes. So will that be something that we're looking for booster? For the general population right now, there is no indication for the booster. We're hanging out there. But again, this will be a month-by-month thing. I think most of us had sort of hoped that this pandemic would be over by now, that we're in the summer months and the numbers would be low and we wouldn't see an increase until fall. But regrettably, we're beginning to see an increase already during the summer months. And I think that's a bit of a concern. The Delta variant of SARS-CoV-2 will likely be the dominant strain globally within months after spreading to 124 countries. The variant was detected in 13 new countries in the week ending July 18th. The global number of new cases rose by 3.4 million in the week, up 12% from the week before. The world added an average of 490,000 cases a day compared with 400,000 cases the week before. And regrettably, the number of fatalities was flat at about 57,000, although any fatality is awful, especially when we can prevent them. There are now more than 190 million confirmed cases of COVID, and more than 4 million people have died. That is a heck of a mouthful when you say that over 4 million people have died. Like I've mentioned in a previous webinar or previous talks I've been able to do, as you know, I work in an HIV program. And since the 40 years of HIV, we have documented about 700,000 people have died from HIV/AIDS in the United States over 40 years. We have more than 600,000 people who have died of COVID in a year and a half. So it's something that we still need to take seriously. We still need to take precautions, but not as much. Is this sort of our time to have a break? I was able to go to the Georgia Dental Association conference recently. I was able to give a talk in front of real live people, which was sort of fun. I love the interaction between people. And so I'm looking forward to our next, when we do our question and answer kinds of presentations. But it was good to be in a room with people. We are social animals, which is why I've always been opposed to calling this social distancing. It should be physical distancing. But literally, it was good to be out in public. Like many of you, I've been to a ball game. I've been with family now. So we are really not in the awful place we were a year ago, but now is not the time for us to completely let our guard down. And I think that's the point I'm trying to make. We have COVID-19 cases rising in all 50 states, which is why I'm making that comment. Now is not the time to completely let our guard down. Regions with low vaccination rates are predominantly or primarily driving the rising rates in the U.S. cases and hospitalizations. And I will actually talk to you in a few minutes about how that's impacting my own personal hospital. The nation's current 7-day average was 26,000 as of July 16th, which was almost a 70% increase from the previous week's average. So we're seeing more and more cases again. And this is due from the CDC's COVID data trackly weekly review. Nationwide hospitalizations are rising, again, particularly in states with lower vaccination levels and outbreaks involving the Delta variant, such as Arkansas, Mississippi, and Missouri. The nation's 7-day average of hospitalizations for the week of July 7th to 13th was a 35.8% increase from the previous week's average. So again, that is showing that we're having people who are not vaccinated, who are getting sick, who are back in our hospitals. And you can just see what's happening in Springfield, Missouri, and other parts of the country where these pandemics are breaking out, or in certain places where they're reinstituting certain kinds of mandates, like Los Angeles County. The 7-day average of the number of vaccines administered was 271,000 or so as of July 15th, and that was a 35.7% decrease from the previous week. And to me, that is really where our problem is. People are getting stuck in their own information zones. Wherever they're getting their information or wherever their fear, they're not getting the full story, or they're just opposed. But when we have Georgia finally reaching the 40% people people in the state being vaccinated, which means 60% are not, that's still a problem. And we're going to let this Delta variant become a problem for us in our dental offices. The 10 states with the highest COVID-19 case increases in the last 2 weeks, this does not include Georgia because it's not reported, but these numbers look very frightening. So if you look at Tennessee, there was a 578% increase. But if your numbers were low to start with, and then you see this jump, then it's important to look at cases per 100,000, where it's 9 cases per 100,000. My other neighboring state of Alabama, their 14-day change was a 574% increase. And their number is significant, where it's 17 per 100,000. Massachusetts, which had done an excellent job on vaccination, had a 472% increase, but then it's 4 per 100,000. Vermont, you can see these numbers, 429% increase. North Carolina, 425, etc. And then you look at states like Louisiana, where I'm really concerned because they already had a higher number, that there are 31 cases per 100,000 people, and they still had a 376% increase in the case counts. Mississippi, again, 21 per 100,000. And we've been talking about some of the southern states and the hesitancy in the Midwestern states and the hesitancy of getting vaccinated, which is problematic because really, if you're vaccinated, you can do more things and feel safer and not end up as one of these cases that we're seeing in the hospital where it's too late to get vaccinated and people are saying, I wish I would have got it done. So we really have to do, as our message, as primary members of the primary care team, is to talk to our patients about vaccination. And if we get a negative response, document it, but don't give up. Talk about how the numbers are increasing, how they can protect themselves and their family, how maybe you were vaccinated and your staff was vaccinated, and what potential side effects you had. Like I've said, when I had my second shot, I didn't really have any issue. When I had my second Shingrix vaccine, I was down for 2 days. So I didn't have any problem with COVID. None of my staff really had a problem with COVID getting the second vaccine. Some might have felt a little tired the next day, but they're protected from ending up with severe illness and death. And that is what these vaccines are meant to do, to prevent severe illness, death, and hospitalization. So if you look at what's happened at Grady Hospital, I am going to share some data. And this report looked at all tests conducted for patients who are hospitalized in the emergency department at Grady. And we are a level 1 trauma center, so our emergency department is very, very busy. And this includes both people under investigation and screening. The employees, such as myself, or external facilities and outpatient tests were excluded from these numbers. So it literally was just hospitalized patients and emergency room patients. For people who had multiple tests, we only looked at their once. If they tested positive, the date of their first positive test is used. If there's no positive test, the most recent negative test was used. So if you look at our results, and at the top of the chart, we start with week 48 here, and that is January of this year. So we were still in winter. You can look at the number of people that was tested. It was 843 tests. 108 were positive for a positivity rate of 12.8 of almost 13%. That was a very high number, but that was, again, one of our peaks of dealing with this pandemic. You can see that in weeks 49 and 50, then we were in February and around Valentine's Day, the number went down to about 10.5, 10.8%, and those numbers were high. Then you see a decrease in numbers going down through March and in parts of April. Then in April, we saw a little bit higher number. There were less people being tested, but the percentage stayed around 8%. And then we got into our summer months. And during our summer months, our percentage of positive tests truly went down significantly until we saw a little bit of an uptake in the last week in June, the first week in July, where there was 2% positive tests. Then the next week, July 4th, and the week after, 4% were positive. And now 2 weeks after, it's 6.8%. So we are seeing an increase in number of people testing positive. We are seeing an increased number of people that were hospitalized. We were down to single digits in people being hospitalized due to COVID for several weeks. And now we're back into double figures. Now we're even over 40 cases. So that's one of the things that we need to keep an eye on. It is active in the Atlanta area, and it's active in most parts of our country. If we look at the percent of positive tests by week in chart form, again, you can see that winter, the numbers were very high. It sort of went on its way down to around May. There was an increase around July, like we just talked about. The numbers were sort of low in September and October. When it got cold, the numbers went up again. Then it started to drop, and now we're seeing another uptick. And this uptick has me concerned because it's the warmer months. We have a lot of UVC in the atmosphere. People spend more time outside. But then again, we're coming back to work. We're intermixing more. And my concern is not about me being around people because I'm vaccinated, but around unvaccinated people being around other unvaccinated people. Then we're looking at the vaccine effectiveness in a high-risk national population in a real-world setting. So this was a study that was actually looking at previous vaccinations. And so with emergency use authorization, which we are still in, although I did see a little headline today that they were going to try to get full authorization from the FDA possibly in August, the latest in January. But with emergency authorization of multiple vaccines against COVID-19, data are urgently needed to determine the effectiveness in a real-world setting. How is it going to work amongst not study participants who sign up, who follow up with their appointments, but people who are actually getting care? And this was done in a very large VA health system. So we looked at the U.S. Department of VA Health. Among the 54,360 persons who tested positive, and the 54,360 matched control participants, the median age was 61 years old, 83.6% were male, and 62% were white. Among those who tested positive, 18% had been vaccinated. That is a significant number to me. Among those who tested negative, 32.8% had been vaccinated. Overall effectiveness of the vaccine 7 or more days after the second dose was 97.1%. This is not 100% coverage. It's not eliminating it, but 97.1 is a pretty significant number and should make you feel pretty safe when you're out in public. It was 96.2 effectiveness for the Pfizer-BioNTech vaccine and 98.2% effective for the Moderna vaccine. Effectiveness remained above 95% regardless of age group, gender, race, or presence of comorbidity. And that's a really important number when we know we have a lot of comorbidities in the VA population, and yet we only had a breakthrough of about 18% or 9,800 cases. The veterans enrolled in care are at higher risk for severe clinical consequences due to the fact that they tend to be older, they have a higher burden of comorbidities, such as I just mentioned, and a higher prevalence of social vulnerability factors. So the VA health system actually provides a real unique world setting to study natural history, disease outcomes, and effectiveness of our new therapies. So what are the dangers of Delta, a summer surge, and mask? And I chose a different expert to talk about this time since I have worked with Carlos Del Rio for over 30 years. He was chief of medicine at Grady. He's an infectious disease physician. Now he is Emory's dean at Grady Health System. And you might see him at certain television stations going on the news. He's been on a lot of TV. If you're vaccinated, you should not worry about the Delta variant. And I think that is a very true statement. If you're not vaccinated, you are really in trouble because it is likely that you will get infected. Remember, the Alpha variant is 50% more infective than is the basic strain. And the Delta variant is 50% more infective compared to the Alpha strain. In the past 2 weeks, U.S. COVID cases increased about 140%, not a great number, and hospitalizations and deaths are up approximately 30%, not out of the woods. Now, again, if you're vaccinated, you're good. Delta is not going to get you. It's not going to be a problem unless you're one of the very unlucky people who has a breakthrough. But we have to try to do a better job in the areas where we have low numbers of vaccination to get people vaccinated. The pandemic is not over, said Del Rio. The global death rate now exceeds 4 million, including 1.8 million deaths last year. More people died in the first 6 months of 2021 and the entire year of 2020. And so we had a whole year of it, and people are still dying. This is still a global pandemic, and you have a lot of strains out there, and it's going to try to survive, and it's going to try to mutate. He attributed the rise in cases, hospitalizations, and deaths due to the Delta variant. Again, we're covered. I want to emphasize the Delta variant is incredibly infectious, highly transmissible, said Carlos, professor of medicine, epidemiology, and global health, and executive associate dean at Emory University School of Medicine at the Grady Health System. So Carlos basically is saying, and I trust Carlos, that we're covered for Delta. We just need to work with getting more people covered for Delta. Who is most likely to develop severe COVID-19 even after getting a second dose? So we want to talk about some of these breakthrough cases. Older individuals with many underlying medical conditions and immunosuppression are more likely to contract coronavirus and will develop a severe case of COVID-19 even after being fully vaccinated, according to a world first study that was conducted in Israel. A minority of vaccinated individuals will contract coronavirus, and a small percentage of those will end up in the hospital. Again, the unvaccinated are who's ending up in our hospital, and those are called breakthrough infections. A team of Israeli doctors, head of infectious disease unit at the Samson Asuda Ashad Hospital, studied 152 fully vaccinated patients from 17 hospitals who developed COVID-19 more than 7 days after they received their second vaccine dose and required hospitalization before the end of April. The cohort was small because not many vaccinated people who contact coronavirus develop a severe infection. Remember, the goal of the vaccines is to eliminate hospitalization, death, and severe infection. And then the vaccine is 97 to 98% effective against the standard variant and is proving to be almost as effective against the Delta variant. Again, more information to make you feel comfortable. So far, despite a rapid spike in coronavirus cases in Israel, the number of serious cases seems to be climbing slowly. And that matches data that we've had in the United States and matching data that we've had from other countries. So how does that affect what we do when we work? I think as far as our outside lives, about being around people again, possibly going to restaurants again and keeping restaurants going and not having to cook, being able to go to a ball game, being able to get ready for football season because we just ended the NBA championships, and congratulations to the Milwaukee Bucks for winning the NBA championship. But as you see, we've been able to do so many different things in our private life. Well, what about our work life? How is this vaccination effort going to affect what we do in our clinics? So the CDC has sort of updated their guidelines and to make them in line with other guidelines. And what they basically said was that dental care providers should only avoid aerosol generating procedures for patients with suspected or confirmed COVID-19. And so my question that I'd like to throw out there is, how do we determine if a patient has suspected or confirmed COVID-19? Confirmed, yes, we would know. Suspected, 50% of the cases are either asymptomatic or pre-symptomatic. So they're going to pass your telephone screening, they're going to pass the temperature check when you get into your office, and you don't know. And so what I would like to say is, I think while we're in our offices now, even if everybody in our offices are vaccinated, we really need to treat every patient as if they're carrying an airborne disease. I sort of talked about HIV in the past. When HIV was discovered and we figured out what was causing it and we figured out how it could be transmitted, we instituted bloodborne pathogens protection. So we wear gloves, we wear masks and eye protection, we wear gowns, all the different things that were instituted that have actually helped keep us healthy during COVID, the initial breakout of COVID. So I think those guidelines were very helpful. But now we also have airborne transmission precautions that we need to take into consideration. And we'll go over those, but simply put, it's HEPA filtration, it's looking at your airflow, it's looking at high volume evacuation, use of rubber dams. I'm a big believer in extra-oral evacuation as well as portable HEPA filters. So there's several steps that you can take to make sure that you're providing the safest dental visit, because 50% of the patients that walk in, we're not going to know. So if you have a disease that has 1.2 million people living with it and out of 350 to 60 million people, and we treat everybody as if they have a bloodborne pathogen, and we have this much more contagious airborne disease out there, why would we not want to treat everybody as if they had an airborne pathogen if you're going to be performing aerosol generating procedures? So previously, the guidance stated that aerosol generating procedures for all patients should be avoided. I don't know many people that have done that. When we put in all of our precautions to enable us to safely treat, we have been performing aerosol generating procedures for some time in this program, and none of the staff have seroconverted. Regardless of so as you can see, the change is only avoid if you have a suspected or confirmed patient. So a suspected patient maybe was in contact with somebody that was diagnosed with COVID. That maybe is somebody you don't want to come to the office, or somebody that was recently diagnosed and not just around somebody. But outside of that, we don't know when people show up to our offices. If procedures for suspected COVID-19 are necessary, the CDC recommends performing the procedures in an airborne infection isolation room that only essential dental healthcare personnel should be present during the procedure. And my question then goes to how many of our practices actually have an airborne infection isolation room? And that could be using, having the airflow go outside. But I actually have a negative pressure room and because I work in a hospital. So my question would be, how many practices actually have an airborne infection isolation room? I think the key is using our existing tools and technology and pre-mouth rinses and all of the different things we talked about to make sure that people stay healthy. All personnel present should wear N95 masks or masks that respirators that provide equal or higher level protection, as well as gloves, gown, eye protection when performing all aerosol generating procedures. That literally should be the standard if you don't know and you're still performing aerosol generating procedures. Procedure room surfaces, just as we've done forever, should be wiped down in between patients. The ADA also has released some new COVID-19 dental office guideline procedures that follow the OSHA recommendations, and hazard assessments are required by OSHA. Dental practices must have a safety plan for exposure control and COVID-19. And I think that is very important because if you don't have this hazard plan and OSHA comes by, they can fine you. They should repeat the hazard assessment regularly as COVID-19 conditions change. This is not a static disease. The virus is changing. Dental healthcare workers should stay abreast of the guidance from federal, state, local, tribal, and territorial health agencies and consider how to incorporate those recommendations and resources into workplace-specific plans. Pre-appointment patient screenings are still necessary. That has not ended as of this point. Staff, patient, and non-employee on-site must be screened prior to office entry, and those with suspected or confirmed COVID-19 should not be permitted. Again, I'm not sure exactly how we do that. We can ask if they've been vaccinated. I mentioned one of the ways that you can stop with pre-screening calls is if they do show you a vaccination card and you can scan it into their chart. You might not have to make the calls the night before or the day before. But again, screening, we have stopped temperature screening for staff because if you're running a fever and you're sick, you need to stay home. If you're sick and you're a patient, you need to stay home because we don't want to, even if it's the flu or if it's the cold or if it's norovirus or whatever might be there, we don't want to share it with our coworkers or our patients. So in the pre-appointment screening process on June 10th, 2021, OSHA issued a temporary emergency standard for COVID-19 in healthcare settings. Most dental offices are exempt from the standard because they fall under the exclusion for non-hospital ambulatory care settings, where all non-employees are screened prior to entry and people with suspected or confirmed COVID-19 are not permitted to enter those screenings. So again, a lot of what's in that document really don't apply to us. You have to have the plan in place. You have to be able to do pre-screening. You have to be able to turn people away if they're sick. And to fall under this exemption, dental offices must continue to screen all who enter their practice in order to ensure people with suspected or confirmed COVID-19 are being kept out. Again, 50% of the cases are pre-symptomatic or asymptomatic, so nothing is 100%. Pre-appointment screening, although there's several different symptoms that are associated with COVID-19, actually having heard that the Delta variant causes more of a sore throat, more of a headache, less of shortness of breath, less of losing the taste and smell. So there can be different symptoms. So when you have somebody in your pre-screening, fever, that's stay home. A new cough, possibly stay home. Difficulty breathing, please get to your primary care provider. Sore throat could be a sign. Muscle aches or body aches. Well, at my age, I have muscle aches and body aches every day, but that would be new, especially if it's a younger patient. Vomiting or diarrhea, and of course, new loss or taste and smell. So these are some of the questions that we ask. Have you been around someone with COVID? Have you been vaccinated, etc.? The ADA did release a new COVID-19 dental office procedures, which is best practice for assessing and managing the hazards in the workplace. And it should take an integrative approach, incorporating evidence-based science data in conjunction with psychosocial state, and community factors. Some areas of say, Georgia are going to have bigger outbreaks than other areas, and so how you do things might be a little bit different. Each dentist will need to use their best professional judgment when making decisions. Our patients expect us to make the best clinical judgments. Our patients expect us to provide the safest dental visit. And so the ADA did release an updated COVID-19 dental office procedures emphasizing the need for hazard assessments, and that came out last week. And what's in the hazard assessment checklist? We do realize that dental care is a critical component of healthcare for all Americans and is considered an essential service. We are part of the primary healthcare team. The guidance developed under the direction of the ADA Advisory Task Force on Dental Practice Recovery provides considerations to implement COVID-19 hazard assessments in dental settings. And there is this wonderful checklist. And I'm going to go over part of the checklist, but you need to be a member of the ADA to be able to download it. That's at least my assumption at this point. There's a supplementary tool to help dentists make a rough calculation of the hazard level presented to staff during one snapshot in time. Users are encouraged to gauge the level of risk under each of the numbered items and then assess the current situation by taking stock of the total number of answers in each column, which sounds really confusing until I actually show you this. So number one, check the disease incident rates in your area. The greatest risk for potential risk reduction would be if the numbers are going down. If there's moderate potential risk for risk reduction is if they're staying the same. And of course, lowest potential for risk reduction is if the numbers are increasing. Regretfully, in Atlanta right now, the numbers are increasing as they are in Louisiana and Mississippi and several of the southern states, and not to mention some of our states in the Midwest. And then we know that Los Angeles is having a bit of an outbreak as well. Check vaccination rates in your area, and you can look at your state website for these kinds of information or look at the CDC. The greatest risk, potential for risk reduction would having mass vaccination levels, so 70% or greater, having both shots. So whether it is both shots of Moderna or both shots of Pfizer. If the vaccination levels are increasing, then there's a moderate potential for risk reduction. And if they're stagnant or the numbers are going down, like I showed you on an earlier slide, that is the lowest potential for risk reduction, putting us at risk. All patients, visitors to the office of employees are screened. Greatest potential for risk reduction is if they are screened. And if they're not screened, then that's the lowest potential for risk reduction. So these are ways of minimizing your risk and figuring out where you are. The length of the procedure needed to treat. An aerosol generating procedure is needed. Is it the greatest risk potential for risk reduction if you're doing aerosol generating procedures? To me, actually, as long as you're following all the guidelines and wearing a fit tested and good sealed N95, it's not going to be a problem. But if you're doing those procedures, you are more at risk in the community. So that's why I have instituted rubber dams and HEPA filtration and all the different things that are called for to have the safest dental visit. High velocity suction being used is going to lead to the greatest risk reduction. Rubber dams being used, again, throughout the procedure will be a greater risk reduction. And if you're not using rubber dam, it's the lowest potential for risk reduction. Respiratory factors presented by the patient that would increase aerosol production, such as a non-COVID-19 cough, gag reflex, sneezing, etc. Physical barriers between treatment areas. Direction of exhaust ventilation, airflow. Remember, we talked about that in the past. You don't want patient air going towards the provider. You want the air behind the provider and heading, if you have a window, that you can open towards the window. HEPA filtration being present is yes, if adequate filtration for the room size is present. And so that is something we have portable units in each of our operatories. Awareness of any individual employee factors that increase risk of infection. Can't wear an N95. Do we want that person really being involved in doing aerosolized generating procedures? So, I mean, all of these answers, you can accumulate a total, and if you're really good as far as risk reduction, you will be in a safer environment. If you're in the red and your numbers are higher, then that's going to cause you to be more at risk. So the bottom line is, We're not quite out of this yet. My concern is mixed with my optimism. My optimism is that we have returned to some semblance of normal. We are doing things again that we would not have imagined doing a year ago. We're going on airplanes. We are traveling to different parts of the country. During the July 4th weekend, the roads in Atlanta were almost not passable. There were so many people traveling through. I got to spend one of my favorite foods is chicken and dumplings. I actually got to spend time with my aunt and uncle in South Georgia, and she happens to make the best chicken and dumplings in the world. I was able to present at the Georgia Dental Association conference in front of real life people and get interactions and get responses. There were things that I enjoy doing. I'm able to have people over for dinner and people to spend time on the outside deck with me now. So those are all the positive signs that we are at. My hope is that we will maintain our diligence of our infection control practices within our offices to make sure that our staff continue to stay healthy, to make sure that the percentage of dental healthcare workers who do test positive for COVID remain very low, that we still follow our basic guidelines that are in place. And that would mean eye protection, respirator of sorts, disposable gowns, gloves, things that we have done now for quite some time. There are some issues with our supplies, and when I say that, it is no longer acceptable, according to the CDC, to use imported respirators. As far as reuse, we are at normal usage. So you really should, if you have the access to, change in 95 respirators in between patients. I will say that I have some staff that don't want to do that, that they want to keep it on at least for half a clinic and they have a shield over it and they stay dry. I am not forcing them to change per patient. I'm just saying that is the recommendation. Recycling or reprocessing N95s, no longer acceptable. Disposable gowns should be changed in between patients, period. Even though I am 100% convinced, or let me make that 99.98% convinced that no splatter or aerosol is escaping all of the tools that we have, we still need to follow the best practices. So that is having a soiled area to derobe and to take off our soiled disposable gowns. As always, it's a pleasure being with you. I hope some of this information proves helpful. Stay safe, stay healthy. Please send in questions because answering your questions is always fun and a challenge, and it helps all of us learn because I don't know exactly what you're thinking. I only know what I hear at different meetings. So again, thank you for your attention, and I'm going to turn it back to Dr. Severance.
Thank you for the timely update, Dr. Reznik. If you have any questions, concerns, or topics for further episodes, please email us at webinars@henryschein.com. And please subscribe to our Henry Schein YouTube channel by clicking the subscribe button and click on the bell icon to be alerted to any new premieres. With that, we'll see you next month with another episode in this series. Until then, stay safe and stay informed.